Hello, everyone. My video is starting slowly, so don't know what's happening with that, but I will start with my slides to try to keep us on time. So can we go to the next slide, Joanne, please? Thank you. Just to introduce Passage Bio, we are a company that targets rare CNS disorders that affect both infants and adults. Next slide, please. And I'm going to focus on Krabbe disease. So if we go to the next slide, I think that you've already heard about Krabbe from Dr. Escolar's presentation. So we'll just note that it is a fatal pediatric neurological lysosomal storage disease. Please go on to the next slide. Okay, so why do we at Passage believe our product has utility? As you heard earlier, there is still, after transplant, some unmet need, especially with the residual peripheral neuropathy and motor changes. In our models, we looked at both mice and canine models, but I'm just showing you the canine model data here, which showed that we had a substantial benefit with AAV treatment, including phenotypic recovery, increased survival, increased GaLax-C, and decreased cyclizine. All of the dogs that were treated had improvement in the central nervous system and peripheral nerve myelination compared to controls. We saw nerve conduction velocities that are comparable to wild type, and that supported us moving into clinical trial development. If you look at the figure there, you'll see the improvement we saw in myelination in both the central and peripheral nervous system. Please go to the next slide. So what is our trial? GaLax-C is a global phase 1/2 trial. We will be doing our first patient enrollment is expected in this quarter. We will start with the first cohort of what I will term as older patients, older being a relative term. It's babies between 4 and 9 months who will enroll 3 of those. And then we will go to the second cohort, which is younger patients, patients who are between 1 and 4 months. Similar to what's been said before, there is a wait period between subject enrollment to review safety data, and that's 60 days to include the compilation of the data, review by data safety boards, et cetera. The study itself has a 2-year duration, and then we will have an additional 3 years of follow-up because we're looking for safety and durability of effect. We want to know that we don't just have an effect early on, we want to know that that effect persists. The primary endpoints from the early parts of the study, though, are of course going to be safety and tolerability. Please go to the next slide. So the gene therapy for Krabbe disease, I know that there have been a lot of talks about how gene therapy works, but we produce a normal, healthy copy of the GaLax-C gene, insert that into an adeno-associated virus, AAV, to make a viral vector. And you hear a lot of people talk about this being the passenger in the car. So the virus is our car, our little gene is the passenger. We want that injected into the cerebral spinal fluid that flows around the brain and spinal cord. Then some of the cells in the central and peripheral nervous system will take up the vector and begin to make functional enzyme, which then will be released into the cerebrospinal fluid. That secreted enzyme can then be used by other cells throughout the body in the hopes of slowing or stopping the progression of Krabbe disease. Please go to the next slide. The key inclusion criteria for our study, you have to be between 1 and 9 months at enrollment. You may be either pre-symptomatic or symptomatic, but if you're symptomatic, you have to have had your first symptoms at under 6 months of age. And this is based, we're comparing this natural history to the one that Dr. Escolar mentioned from Beltran, published in Orphanet, looking at that particular group of patients. So we also will want to see leukocyte GaLax-C activity below the lower limit of normal, whole blood cyclizine that is greater than 10. The child, because it's the gene therapy, we will have to have evidence that the child actually has pathogenic GaLax-C variants that have previously been associated with early infantile Krabbe, or that the child has variants that are classified as likely pathogenic. If, as I mentioned, you may be either pre-symptomatic or symptomatic, if children are symptomatic, they have to have a minimal level of neurologic and developmental function that indicates they have the potential to benefit from treatment, at least with slowing or stabilization of disease, because anything has risks and you want to show that you have some potential to provide some sort of clinical benefit to patients. Okay, so the subject has to have the following clinical features when age appropriate, because obviously these are children who are under 9 months and different skills develop at different ages. So when age appropriate, the child has to thrust their legs in play. They have to be able to lift their head, follow a moving person with their eyes, smile in response to a speaker's attention. Please go to the next slide. The study has 3 components. So we have screening, dosing, and follow-up. And I just want to, I should have said before, our clinical trials identifier is at the bottom of these slides so that you can get more full details should you wish to go to clinicaltrials.gov. Next slide, please. Okay, so during screening, we will actually ask the investigators to determine whether a child is eligible for HSCT. Though HSCT is not an approved therapy, it is a therapy that has a lot of documentation, and we, in discussions with regulators, decided that patients and families need to know all their options. So therefore, all patients will be assessed to determine if they are eligible. And if they are eligible, that option will be discussed with them so that they can make an informed decision about whether they wish to go to HSCT or enroll in the trial. Then we also will look at MRIs and MRAs because we need to know the anatomy of the child's posterior fossa to determine whether the Intercisterna Magna administration is appropriate. Children will have physical and neurological exams. We will do some neurocognitive testing, Bailey, Vineland. We will get an impression of severity, and we will do various quality of life assessments. Next slide, please. I just want to touch on the Intercisterna Magna, and it is utilized across our programs to directly target the CNS. And so we will be delivering the vector into the CSF via a single injection that reaches both the CNS and peripheral tissues. This allows for broad CNS biodistribution, and we will be able to use lower doses compared to IV systemic delivery. You heard it commented before, the concern about immune reactions. Actually delivering into the CSF has a reduced impact of neutralizing antibodies, though as part of our safety monitoring, we will be monitoring for neutralizing antibodies, which I think is done with all types of gene therapy, whether it's given as adjunctive treatment or not. The product is administered under anesthesia to allow for precise delivery. And as I said, this type of administration is being used in several clinical studies in both pediatric and adult populations. Next slide, please. So the child will have the ICM procedure. They'll be hospitalized for a minimum of 48 hours. The families will be asked to stay within 200 miles of the dosing site for 30 days following the procedure to allow this close monitoring. And obviously, we will provide food and lodging for families who don't normally reside within that 200-mile radius. Next slide, please. We assess neurodevelopmental status over time, as well as physical and neurologic signs and symptoms. We will have multiple visits in the first year, but then approximately yearly visits after that. Next slide, please. There are, of course, risks associated with anything. The risks associated with the virus. There is a risk of liver inflammation, and some of you may be familiar with the other AAV therapy used for SMA and the fact that Zolgensma does do has had some liver inflammation reported, for which people get corticosteroids to try to mitigate that. There's always a risk for nerve damage, inflammation caused by the injection, or lowering of platelets. There are risks associated with the procedure itself, such as bleeding, discomfort, anesthesia risks. We do give a complete list of risks in the informed consent form. Of course, this is a first-in-human study, so there may be unknown risks, but we will be following very carefully to maximize safety in our subjects. Next slide, please. Where will we enroll patients for the trial? We will be recruiting worldwide. We will have study sites in the following countries: US, Canada, Brazil, UK, Netherlands, and Israel. And we will fly patients from anywhere in the world to one of these study sites. And I should just mention the specter of COVID, which can impact some travel at this time. But we have a concierge service that is working with people to try to arrange travel and facilitate that whenever possible. Okay, so I think that the next one is my last slide. And I thank everyone. I especially appreciate Hunter's Hope inviting us to talk about the study. And I would note there, there's information for patients and caregivers. There's an email address there for healthcare providers. There's also an email address. If you have patients that you'd like to refer, please send those referrals to the email addresses you see on the screen. And just, I saw Dr. Kurtzberg, and I agree, the FDA does not have jurisdiction over HSCT, but it is indeed standard of care right now in the US, though not worldwide.